Hereby I open this academic ceremony in which Mirko Belliato will defend the academic thesis, The Use of Extracorporeal Life Support Systems in Patients with Acute Respiratory Insufficiency. May I invite you to present a summary of your work and the conclusions of your thesis.
Thank you, distinguished prorector. It's an honor for me to present my my research, and I would like to start with the first slide. It is the title, The Use of Extracorporeal Life Support System in Patients with Acute Respiratory Insufficiency. What is an extracorporeal life support system in acronym and ACLS? It's a non-therapeutic, life-saving and invasive procedure for heart and respiratory failure. It could apply to the patient with the cardiac insufficient or respiratory insufficient. And in this dissertation, I will focus on the respiratory insufficient with patients that suffer from a very well-known pathology in the last 2 years during the COVID era, the RRDS, the Acute Respiratory Distress Syndrome, for example, for the COVID patient. But which is the ECLS system mostly used for the respiratory failure? This is the first question that I have to answer. The ECMO, the extracorporeal membrane oxygenation. The ECMO is the provision of oxygen and carbon dioxide exchange through the use of a circuit that minimally consists of a tube, a pump, and artificial membrane lungs, plus the cannula that are inserted in the patient. The ECMO circuit, as you can see on the screen, it's mainly done by the oxygenator. You can see at the bottom there is a heat exchanger that permit to keep the blood at the 37 degree as the human temperature, and the gas supply and the pump that can perfuse the lungs with the blood of the patient. There are several types of ECMO. One type is the VA ECMO that is used for cardiac support. The respiratory ECMO, the name is VV ECMO, venous ECMO, and there are the full support. The name is hybrid ECMO, that is a combination of the first two types of ECMO, VA and VAV. We focused on the VV ECMO and the patients that suffer from respiratory insufficiency. This is a schematic view of the lungs, natural lung of the patient with the light blue color, and the light green color is the membrane lung. The patient, it's like a factory that consumes oxygens and produces CO2. The circulation of the patient still remain done by the spontaneous heart beating. So the heart move the blood inside the patient, so that means that there is no cardiac support for patients that are treated with venous ECMO. The aim of the research is to enrich the management of patients under ECMO support for respiratory failures in terms of understanding the performance of patient lungs and the membrane lung efficiency, and optimization of ECMO function for minimizing the impact of ECMO, for example, the hemolysis. This is one of the problems of ECMO patient, on the organ function to allow the maximum support for the patient. I go through different point during my research. The first one is answer to this question, which is the major benefit in terms of lung stress offered by ECMO support. We try and we have done the validation of a new device for measuring the carbon dioxide eliminations that is identified as one of the variables of to control the lung recovery. After that, we moved to study a new parameter that is not explained in the literature till now, about the ECMO performance and the natural lung patient performance, to understand the winning of the ECMO. After that, we asked which is the impact of ECMO support to blood rheology, in specific on the hemolysis, and at the end, we answered to the question which could be the best configuration in terms of cannulation. So I mean with cannulation, the cannula that are put inside the patient for drain and give the blood treated to the patient for reducing the risk of neurological complication. To answer the first question, which is the major benefit, we start from the equations of power, energy that the patient need to ventilate. And you can see here the energy is done by different components, as the energy for distend the lungs, to move the gas, to keep the lung open, multiply the times that this happens, that is the respiratory rate. We want, when we treat a patient, to reduce as much as possible the energy applied to the lung, the injured lung of the patient, because the patient have injured lungs, so they're not healthy patients. So for this reason, we made a pilot study, a proof of concept study, in which we study which was the mechanical power in MP before the ECMO and after the ECMO. And you can see on the screen that there is an important rise down of the mechanical power during the ECMO support in the first days of ECMO support. Plus, we study the PEEP, plateau pressure, peak pressure, delta pressure, respiratory rate, and the tidal volume. In this table, it's summarize our results that is mainly focused on the respiratory rate, the results, because we identify as independent variable of success of outcome of the patient with the very low respiratory rate compared to patients that during the ECMO support are maintained with a respiratory rate higher than 15. This is the cutoff that we use. The statistical analysis gives us the information that the respiratory rate is one of the main determinants of energy transmission and should be kept low as much as possible. The validation of a new device, it's mandatory for testing and measuring the carbon dioxide. And we have done this experimental study in lab on pigs, and we compare two different, a new device to the standard method, that is the use a normal capnometer that give us the information of percentage of carbon dioxide in exhausted gas from the membrane lung. We compare this classical standard one with a new device that automatically measure the gas flow, the CO2, and give the volumetric elimination, means in terms of ml per minute of CO2 during the ECMO support. That is the first step to answer to the second question. So which could be the component that we consider main important for the studying of the native lung performance, and we trust that the carbon dioxide elimination could be this kind of parameter that we have to measure. And we prepare a pilot study that was conducted in a multi-center configuration based on this concept. If the patient is the factor that produces CO2, this CO2 is eliminated by the lungs and by the membrane lungs. And this is the equations, simple equation. So the total elimination of CO2 is the sum of VCO2 of the membrane lung plus the VCO2 of the native lung. This is the flow chart of the study. We included at least 18 patients with different RDS type, as described on the screen. But how to standardize the value of CO2 elimination to understand which is the component of a native lung, which is the part of CO2 elimination given by the native lung. And we try to study the ratio, the name is VCO2 ratio, for every patient in our study. And we decide on basis of clinics and after that with statistics that VCO2 ratio greater or equal to 0.4 remains a valid value to detect the start of the weaning. And if the measurement of the VCO2 ratio after this cutoff remains positive, that means the trends after this cutoff is positive, you could assess if the patient could be weanable or not. In clinics, we demonstrate this and we apply the cutoff. And you can see here that is all the patients staying in ICU on ECMO support. We divide in quartile the ECMO run length. You can see that there is an important difference, also statistical difference from the first quartile to the last quartile when we reconnect the patient. About the patients that were unweaned, you can see here these are 3 patients that that only 2 arrived to the cutoff, but the patient died for not respiratory disease, cardiac arrest 1 and intracranial hemorrhage. And the last patient with the stripe, you can see here there is no increase and died on ECMO for respiratory insufficient that never the native lung never recovered. But which were the mechanical ventilation setting and the ECMO blood ECMO setting before the cutoff and after the cutoff. And you can see here that the p-value never was significative. So that means that the VCO2 ratio is independent by the settings done by the clinicians. So it's like anatomical or physiological or functional variables that not depend by the settings done by the caregiver. But which is the impact of the extracorporeal support on blood rheology? We start to study the hemolysis with this retrospective study, in which we apply this kind of circuits: patient on ECMO plus CRRT dialysis, continuous dialysis machine. And we connect, as is demonstrated in recirculation on the oxygenator. What we found? We found that the aptoglobin variation depends from the ECMO blood flow, obviously, depends by the CRRT application. So patients with the dialysis have a lower, an high variation of aptoglobin with a lower aptoglobin, and the dead space of the membranous lung. That means that there are clots inside the membranous lung that cause hemolysis. And what about the free hemoglobin? You can see here that all other parameters are not statistically significant, but the CRRT still remain significant, because the two, aptoglobin and the hemolysis, the free hemoglobin, are different kind of parameters. The aptoglobin could be affected, but others component. The free hemoglobin is more pure to study and give us the information that the dialysis is the main elements that cause alteration of blood rheology in terms of the hemolysis. As last step, we answer to this question: which could be the best configuration in terms of a cannula system? I mean, double cannulation, single cannulation, single lumen cannulation, that means 2 cannulas, for reducing the risk of neurological complication. And we have done this retrospective study based on the ELSO database. And what we found, we collect the data, and we found many different, statistical different, with no weighting with the propensity score parameters. That seems to be strange. So the type of cannulation, single lumen versus double lumen, can affect the survival rate, the PO2, plus the outcome of the patient alive at the hospital discharge. So this could be a confounding factor or or not. So the occurrence of neurological injury depends on cannulas type or not. So we need to apply a very complicated statistical method that based on artificial intelligence, and we obtain that there is no difference, statistical significant difference between the two types of the cannulation setting. As a conclusion, this research demonstrates the safety and efficacy of ECMO as a respiratory support for severe RADS patients and suggests to use a new index, the CO2 ratio. Could help to detect the right time for ECMO liberation. The connection of dialysis affects the blood rheology in terms of hemolysis, and double lumen jugular or two cannulas, single lumen, do not affect the neurological complication of the patient. Thank you so much, and now I would like to give the word to the distinguished prorector.
Thank you for this interesting presentation. The opposition will be started by Professor Van Mook, Professor of Intensive Care Medicine, Maastricht University Medical Center.
Thank you, Mr. Prorector. Dear candidate, congratulations on a thesis well written, 5 original studies published in well-recognized medical journals, easy to understand. I really enjoyed your presentation as well. And would like to extend my congratulations also to your supervising team, Professor LaRusso and Professor Maas, who's unfortunately not here today. But, and there's always a but, because we have to ask some questions and we have to engage in dialogue. And I would like to start with some questions on Chapter 2. You nicely alluded to that already in your presentation, the chapter on mechanical power during VV-ECMO, the pilot study. I've got some questions. I'm not an ECMO expert, but I noticed that from the 151 patients, you included 35. Where are the remaining patients? Why did you exclude them? Did I miss that in your paper, or would you be so kind to explain it to me?
Thanks, distinguished opponent. My answer is that we try to enroll patients with all the data. So one of the problems was the obtaining the volumetric capnometry for the native lung. This is a technology gap, and we had to have patients with the proper ventilator and the proper probe to record, measure, and record the volumetric capnometry. That is not the entitled capnometry, the entitled CO2 value. This is one of the reasons of this. So the lacking of data is more important, and plus the kind of complication that occurs during the first hours could affect the prolongation of the study, the enrollment. The dropout was due to mainly lack of data. And sudden death of the patient in the few hours after.
Right. So, in fact, you're stating it's a highly selected population based on practical consideration.
Yes.
I understand. Coming again to selection, because they're all ARDS patients. And in fact, I'm a bit opposed to the concept of ARDS, because as clinicians, we know that the adult respiratory distress syndrome, obviously all these patients fulfill all criteria, but the underlying disease is very different. So a traumatic patient with pulmonary injury is a different patient, merely needing support compared to a bacterial pneumonia patient, compared to a uroseptic patient, for example. So different underlying diseases, different disease courses, but all fulfilling the criteria of ADS. So you included all these different patients in your study. Why not select one kind of?
You are totally right, Mr. Because we didn't know if there is any difference in terms of lung recovery. Probably if we performed a very small study, this is one of our bias or limitation. My idea was to repeat with a large number of patients with different type of RADS, primary RADS, secondary RADS, to detect if this is a variables of CO2 elimination in terms of VCO2 and lung recovery. We included all because there is no suggestion from literature about distinguish this kind of patient in terms of CO2 eliminations. Probably there is a difference in terms of dead space, pathological dead space from primary ADS and secondary ADS, but it was very, very weak, the publication on this, so we don't feel confident to exclude a part of these patients.
Right, but you're planning to do a study. What type of ADS patients would you choose if you would select a certain group of patients?
I think that the primary ADS will be the best because it's really the lung affected, like the COVID patient. Yeah. It was a perfect moment, right. Experimental moment, the RADS of COVID patient, but as you know, there was no time, not sufficient energy to do this kind of study during the pandemic, but right. You are totally right.
For the pilot study, obviously I understand that you performed it the way you did. Can I ask one additional question, Mr. Prorector? On page 37, you mentioned that the mechanical power value was categorized according to the threshold for VILI, ventilator-induced lung injury, from an experimental model. I think you referred to Cressoni, 12
yes.
joules per minute, the study
yes.
anesthesiology in 2016.
Yes.
I looked up that study. It's done in piglets.
Pigs, yes.
Right. So
right.
How can you be sure that it's generalizable to the human population? And in the discussion, you mentioned a different study with a different threshold.
Yeah.
So my question would be, do you still support the threshold that you chose beforehand, or would you have chosen a different threshold in retrospect?
Honestly, we have tried to apply in clinics after this pilot study, and it seems that the threshold it's proper, it's correct. It seems that the pigs can give us the right informations about this. But you are right that it's not a human study, and probably we have to perform a step back study on humans to understand well this threshold of that you mentioned, but at this moment seems to work on humans, but honestly we assume that this is right.
Exactly, and the argument you put forward in your discussion is the 17 joule threshold increased mortality.
Yes.
So
17 probably in humans is 15 or 18, but it's very near.
Yeah. Thank you for your answers. I will convey back to the prorector.
Thanks.
Thank you. The opposition will be continued by Professor Müller, Professor of Intensive Care Medicine, Regensburg University. Thank you for joining.
Thank you. Good morning from Regensburg. Dear Mr. Candidate, congratulations on your nice presentation. I would actually start my opponent by asking a question about CO2 elimination. Two of your studies which you presented dealt with the elimination of CO2 by extracorporeal support. You are probably aware of the REST trial, which was published in 2021, which was a randomized controlled study on CO2 elimination in moderate lung failure. The REST trial was prematurely terminated after about 400 patients were included for futility. And in addition, severe complications were actually increased in the ECOR group. So my question to you would be, do you believe that ECOR still has a place in clinical practice? And could you justify your opinion?
Thanks, distinguished professor. I believe that a proper CO2 removal device, ECOR device, could help if the performance can be done is enough power. There is enough power to remove at least 70-80 ml per minute of CO2. The actual device of ECOR, the major part in standard setting means patients with quite high PCO2 and not safe ventilations can assure only 50 or 60 ml per minute. As demonstrated by the supernova study, the subgroup of patients treated with powerful ECMO support, that is means in reality was a mini ECMO applied, allow lung protection strategy. I'm not so sure that the dialysis machine converted to ECOR device can assure always lung protective strategy. I know that on the market will arrive others ECOR device that probably could answer better to this question with the very low blood flow. But I believe that it needs more than 400 ml per minute of blood flow, and not all the ECOR device can assure it.
Okay, thank you very much. All devices I am aware of seem to increase severe complications, mainly due to bleeding and thromboembolic complications. Would you say for the future, what could we do to decrease this amount of complications?
Thanks. There are two strategies that are under study. One is to use the citrate. One is to use the local anticoagulation system with the citrate or protamine, heparin and protamine, or citrate and calcium, but still not tested in terms of performance. There are a couple of devices that use the citrate derived by dialysis concept, but I don't have seen until now strong data about the performance that can allow the lung protective ventilation strategy.
Okay, and concerning which indication do you think would be the right one in general? Yeah, we have two groups. There is one group saying we have to treat those who have hypercapnia, exacerbated COPD, and use extracorporeal CO2 elimination. The other group says, no, we want to treat moderate ARDS to decrease the aggressiveness of ventilation. So what would you say? Where's the future for ECOR?
I strongly believe that the future could be the COPD. The moderate ARDS still remains a very small population that cannot remains moderate during the stay in ICU. Can becomes severe, and you have to switch to an ECMO support. At the opposite, the COPD is a well-studied patient, and the exacerbation can be understood well, and you could apply a lower power in terms of CO2 elimination chronically on this patient, and could probably have a more successful this technology in this kind of patients.
Thank you very much. I would refer now to your fourth study. In one of your presented publications, you investigated the incidence of hemolysis on ECMO. As we all know, severe hemolysis was a big problem in the old devices. but should not regularly occur in modern devices. On this background, do you think we should nevertheless measure free hemoglobin on a daily basis? Now, and what can be done to avoid hemolysis in clinical practice? And what should we do if severe hemolysis occurs?
My center, we tested every day the hemolysis. It's one of the standard, and not the aptoglobin. We use the aptoglobin in the first 5 days, 3 days, because the aptoglobin is multi-affected parameters. The free hemoglobins, no. I think that avoiding the connection of the CRT to the ECMO could help. Because nowadays there is no connectors that are studied and created for this kind of application. Now we use a Luer lock, and you know the Luer lock holes are very thin and very small, and this is one of the reasons. There is no setup really that can be really used safely for using the CRT connected to the ECMO. Honestly, I know that it's very simple to connect the dialysis machine, but you have to consider to use the connector types that can affect the clinics of your patients.
Thank you very much. I would give back the word to the prorector.
Thank you for your participation. The opposition will be continued by Professor Grasselli, Professor of Intensive Care Medicine in Milan. Thank you for joining.
Thank you. Thanks, Mr. Candidate, and congratulations for your thesis work and for your dissertation. So I have 2 questions for you, and the first one is, can you please tell us your opinion about the optimal cannulation strategy for severely hypoxemic patients, with maybe some insights on the possible role of the cannulation strategies on ECMO-related complications, not only on neurological complications.
Thanks, eminent professor. It's a good question because it's a very challenging question. The severe hypoxia patient need high blood flow. The high blood flow can be assured by high size or diameters cannula that can be put in a central configuration, cannulating the venous cava directly from the thorax, but we know that the complication could be higher, complication infective and bleeding. So one of solution is to use the jugular vein as drainage, and the immixtion, the inlet cannula in the atrium through the femoral vein. This seems to be the more powerful system, but could affect also with complication. The malpositioning of the jugular cannula is quite often, happen quite often, and the risk of high recirculation on the basis of the movement of the cannula could happen. So at the opposite, using the very high diameter or high size multi-stage cannula in the inferior vena cava, and the inlet cannula in the jugular vein with the basket tip cannula could be a compromise between the complications of bleeding or local complication, local infections, malpositioning, the accidental decannulations, and the power of your ECMO. You can achieve till 5 or 6 liters. I would like to underline the type of the cannula. Multi-stage cannula, quite short and with a big size, could be the right choice. Higher than 25 in adult male normally could be used for the severe hypoxic patient. If this is not sufficient, you can switch to an hybrid configuration, moving from venous ECMO to venous venous arterial ECMO. This is could be done if the patient is affected by also hemodynamics problem like right heart failure due to the severe hypoxia and collapse of the lungs or consolidation of the lungs. This could help to maintain higher the blood flow and higher the oxygenation. Obviously, the secret don't exist. There is no the perfect cannulations. But in my opinion, using this kind of approach, it's a compromise between the very high support as is done in Karolinska Institute, for example, from jugular to femoral, that is the most power. It could be better for me using the femoral jugular inlet. The double femoral cannulation is the cannulation with less complication, more quick to do, more fast to do, but the power could be lower than this cannulation. We perform half patient with the femoral and half patient with femoral jugular, depends on need of oxygenation. That is no problem for CO2 elimination, because normally plus than 1 liter it's enough. 1 liter of blood flow.
Thanks. But do you have any? We have seen from your study that apparently there is no relationship between the cannula configuration and the incidence of neurological complications. Do you know whether the cannulation strategy can affect other complications, like, for example, infectious complications?
Yes, you are right. The infection complication is one of the biggest, the main complications that could be affected by the patient, particularly the venous configuration or the venous jugular configuration in patient tracheostomized, because the distance between the insertion point of the jugular cannula and the tracheostoma is very small. So the oral bacterial can move on the cannulas, and plus the cannulation of the ingro could be affected by intestinal bacterial, and in patient with severe problems of gastroenteric disease, for example, it is one of the problems that we recorded in this year. Other complications are the thrombosis, distal thrombosis, particularly in the legs, cannulated, the distal arm, the distal leg, part of the legs could be affected by deep venous thrombosis, and the inferior vena cava also, if you use not lighthouse tip cannulas, because the major part of the cannula don't have hole, and there could be stagnation of the blood around the cannula inside the inferior vena cava.
Thank you. And my second question would be, can you describe how does the setting of the mechanical ventilator in ECMO patient change along the extracorporeal support run? I mean, let's say from the start of the support, from the connection of the patient, the initial connection of the patient, to the weaning phase.
Thanks for the interesting question. Nowadays, there is no protocol that is approved widely worldwide, but there is several studies that give us the information that after the cannulation, you have to reduce the impact of the ventilator's damage, injury on the lungs. So reducing the transpulmonary pressure, reducing the FiO2 for the superoxide disease that can affect the lungs, reducing the respiratory rate and the tidal volume, lower as much as possible in terms of delta pressure. There is not yet a cutoff. My suggestion is to keep in mind the rules of lung protective ventilation. So when you start an ECMO support, immediately goes down to the lung protective ventilation strategy and follow these rules and reduce the respiratory rate. When you see on the volumetric curve the apparition or the third part of the curve of the volumetric capnography curve returns clear on the screen, started to reventilate the patient with higher tidal volume, maybe from 3-4 ml per kilogram to 4, 5, or 5, 6, and with a low frequency, and checked the CO2 elimination in terms of volumetric ml per minute, if something happened, and in terms of shape of the curve. If the third part of the curve returns visible and quite long, I mean, you can proceed to the weaning of the patient and increase the respiratory rate, and checked if the CO2 and the oxygenation it's right. In the meantime, meanwhile you have to reduce the FiO2 on the ECMO. We used to balance the FiO2 between ECMO and the ventilator, and we go down together, synchronizing the ventilator FiO2 and the ECMO FiO2 to reach a very low VO2 given by the ECMO. And VO2 is the amount of oxygen in terms of ml per minute that the ECMO can provide to our patient. We can measure it, and we reduce the total VO2. We don't touch the blood flow. We touch only the gas flow and the FiO2 on the ECMO. And on the ventilator, we change both the tidal volume per kilograms and the respiratory rate, but we take care about the transpulmonary pressure. If we can, we use the esophageal balloon to understand the real transpulmonary pressure, not the total driving pressure.
Thank you very much for your answers. This is enough for me, and so I pass the word back to the prorector.
Thank you for your participation. We continue the opposition with Dr. Gavinales, Associate Professor of Pediatrics, Maastricht University Medical Center.
My congratulations for the work you are presenting. The topic you started is extremely relevant in critical care medicine, and you have added important data and developments as well. In addition, and I believe it extremely that your preclinical research in Maastricht and your clinical work in Pavia are complementary. And my congratulations to the promotion team as well, to Professor Russo and Professor Maassen for this productive collaboration. Dear candidate, I would like to ask you two questions related to chapter 6. As you stated, ECMO could lead to acute neurological complications which dramatically affect the acute neurological outcome of patients. Therefore, close neuromonitoring, early identification, timely intervention is very important to diminish early but also late neurological morbidity. The first question is, which modalities do you use for neuromonitoring during ECMO, on ECMO in your unit?
Thanks, distinguished professor, for the question. You underline an extremely important point, because the ECMO patient are can be mobilized, but not very easily. So going to do a CT scan, it could be a problem. The MRI is not possible, but there are some case report that I have done, but I don't know how. We use daily we try to keep the patient awake as much as possible. in terms of neurological examination, clinical and neurological examination, to understand if something happened. But we know that not always is possible. We have to control the respiratory rate with the sedative and curarization. So we have to use technical tools. One is the NIRS. We use the NIRS in patients that we cannot awake daily to check if something happened in the trend of the NIRS, the oxygenation and perfusion. That is both the meaning of the NIRS. It's a parameter that measures oxygenation, but mainly the perfusion of a part of the brain. There are several. You can use 2 or 4 probes to connect to connect to the machine, to understand different, to explore different parts of the brain. Plus, you can use the pupillometry. If something happened to the daily examination with the pupillometry, it's a very bad signs, and can be related to cerebral damage, cerebral injury. And at the end, the EEG, continuous EEG, could be a very quick, costless tool. The problem is to study, to understand which are the meaning of the EEG curves. But the EEG could be interesting to use in the ECMO patient, both VV and the VA ECMO, because many patients with the VV ECMO have seizure under the sedation, and we didn't know. We discover when we disconnect the patient from the ECMO at the CT scan, and we found the ischemic lesion. Please.
Well, good to hear the importance of the clinical situation of the patients and the brain function you monitor. What about neural-derived biomarkers? Do you use it?
Yes, we use the NSE at the beginning of something happen in our clinical examination. There are also the SB100 that we don't use so much, and we want to do. I hope to do with this university a study on neurofilament and the sphingolipids. Obviously, these are research parameters that cannot be done actually in clinics, but we hope to win a grant in the next month and start with a multi-center study with Maastricht, Erasmus, Brussels, and the Karolinska Institute about this question that you have posed to me, which are the biomarkers combined with the NIRS that can help to early detect, because not always there are so fatal, so severe events that cannot be treated by the surgeon. We performed neurosurgical intervention in patient under ECMO, but we detect early the complication. If you wait 1 week after intracranial hemorrhage or severe ischemia with the edema, it's late.
This is the Acute is an on-ECMO neuromonitoring. What about the follow-up, the longitudinal follow-up?
You are right, but you touch a point that in my hospital we are lacking, because the long-term complication, neurological complication, behavior complication, psychiatric complication are one of the future topics in our field, particularly in the pediatric area, in which you need a program, a specified program, prepared program for following the kids, for following the adult, the young adult that can have problems after 6 months, after 1 month, to return to the previous life. In my hospital, unfortunately, we don't have it, and I fight to have it, but you know that is not so simple, because plus the surgeon and the intensivist, we need a psychologist, a psychiatric, neuropsychiatric, and neurologist. So this is a quite important point to solve. Thank you.
Thank you, and thank you to tell us about your situation in the hospital and future improvements as well. Thanks a lot.
Thanks.
Give back the word to the prorector.
Thank you. The opposition will be continued by Professor Taccone, Professor of Intensive Care Medicine at Free University in Brussels.
Eminent Prorector, thanks for introducing me, and I have to commend the candidate and the supervisors for this very nice work, which has underlined how many gaps in knowledge we have in this field. So, dear candidate, first question would be about the free hemoglobin. So you mentioned that there are some factors that influence hemolysis. You mentioned the dialysis. You mentioned maybe anticoagulation. My question is, do you think that transfusions that are frequently given can influence one of the two parameters, haptoglobin or free hemoglobin? And how much the different membranes of ECMO, different component and industries can impact this finding?
Thanks, distinguished professor. Yes, the coagulation is affected by the hemolysis, and the transfusion rate probably can affect the hemolysis rate because the transfused red blood cells are less plastic than the native red blood cells. And the half-life of the red blood cells transfused is less, almost 1/3 of the native ones. We tried to check if there is any statistical correlation, but we don't found. Probably it is a limitation in terms due to the numbers of the patient enrolled, and this phenomenon should be tested with a different type of study, prospective, not retrospective, with the high number of patients that receive transfusion for a long period, and check the hemolysis precisely after the transfusion. Plus, the coagulation is affected. Also, the APTT is different because the free hemoglobin is an inflammatory variables that can affect the inflammations of the patients. And what about the different membrane? We check in this study two different membranes. One is with a square oxygenator, and one is a cylinder oxygenator. So not only the membranes, but also the geometry of the oxygenator, the membrane lung, is different. And we found that there is a slight difference in terms of prolonged higher blood flow, but higher hemolysis and higher APTT. That could be I'm not sure, obviously, that could be the result of alteration of the coagulation for inflammation. But obviously, there is high blood flow. And if you need high blood flow, because your patient is hypoxic, you have to accept high hemolysis and alteration of the coagulation. I think that you underline a point that the science not have already solved. The perfect oxygenator that is not square and probably is not cylinder. The membrane seems to be good, but we have to learn a lot about bioengineering of the device, of the membrane lungs.
To remain on the same topic, I would like to echo what Professor Grasselli has said. Do you think that the cannulation configuration, so double lumen, single lumen, have also an influence of hemolysis?
Yes, if you use flow that are not proper for the cannula type. If you choose a 21 French cannula for single lumen drainage and you want to do 5 liter, you cause hemolysis. If you use a double lumen cannula of 31, and you want to do 10 liters, it's impossible, and you cause hemolysis. So yes, you are right, but this kind of phenomenon is a phenomenon that we expect. We know this kind of problems, complications of problems due to the cannula type. I don't know if combining the standard or proper blood flow with these two type of cannula, you have a higher hemolysis respect the others one. In the study there is no point. This point is not treated in the study, but could be an idea for future using the two different type of cannula, but in a correct way. So we have to cut. We have to select the patient properly to do this study. Not all the patient.
You also said in your study that you use APTT to titrate anticoagulation, and some teams now today after COVID, they move to anti-10A activity.
Yes.
So we know that the results are not entirely comparable. Do you think that if I use one strategy, APTT, on the second one, anti-10A, the effect on hemolysis, or maybe even membrane survival, will be different?
Probably yes. Because the correlation of the A10, as you want to say, is stronger with the coagulation set of the patient. The setting of the coagulation, the balance of the coagulation balance could be more precisely explored with the anti-10 than the APTT. But it is very gross parameters that can be affected, but several phenomena. It is more correlated, the anti-10, to heparin activity, and probably could be. The problem is that in my center, the anti-10 arrived after 8 hours. I don't know in the other center, but in my center is 8 hours, and this is a problem. So we use it once a day, once every 2 days, just to understand if we are moving right with the APTT or not. We moved with the APTT at the bedside with the device during the COVID period for reduce the number of in-out from the COVID area, and we use the APTT inside, and we use the anti-10 just to check.
Okay, thank you for your responses, and I give back the word to the prorector.
Thank you. The opposition will be continued by Dr. Driessen, Associate Professor Intensive Care Medicine, Maastricht University Medical Center.
Thank you, Mr. Prorector. Dear candidate, congratulations on the finishing of your thesis. Of course, I would also like to involve your supervisory team in my congratulations. For the sake of time, I will continue to the questions. And my first question would actually go back to the introduction of your thesis. Because, of course, you describe some complications of VV ECMO. And as a clinician and an intensivist, I'm also interested in to avoid VV ECMO. And one strategy might be prone positioning. And on page 12, you state that prone positioning did not demonstrate a survival benefit. However, you refer to a meta-analysis from 2012, and maybe you were aware that 2013 the ProSEVA trial came out, and which did show a benefit of proning if you do it for a long time, so 16 hours was mentioned. How do you think about that? Do you do proning before you go on ECMO?
Thanks, distinguished professor. You are right. In the introduction, I state the old thinking about this prone position, because during this 2 years and a half, we are involved in studies that I just published a couple of months ago. So we didn't know before that the prone position is effective. Before ECMO is effective, and during ECMO. During ECMO, prone patient can reduce the ICU stay and can improve the survival rate. I cannot state this before because the data was not available yet, but you underline a very strong point that is a treatment that we have to do in RDS patient before going on ECMO. just maybe one time for 12 hours, 14 hours, just say no. There is no answer. There is no benefits, and we move to ECMO. But nowadays, I should change and move to the whole now concept that the ECMO can be done before, should be done before, and can be done during ECMO support to reduce the complication.
Thank you. I completely agree with you. I'm satisfied with the answer. Interesting that you state you also do prone positioning in patients on ECMO. In my center, I think we didn't do it because we didn't dare to do it with the mostly femoral cannulation. What is your opinion on that? Does the cannulation play a role in prone positioning on ECMO?
Yes, some Italian centers, Milan, perform a lot of femoral cannulation, and also they prone the patients without any problem, just to keep attention to kink the cannulas and the tube that underline the legs of the patient. In my center, that we do both jugular, femoral. The jugular cannula, it's okay for proning, but you have to remember to have quite long circuits to prone the patients. But the complications are very low.
Mirko Belliato, the time appointed for defending your thesis has passed. The degree committee will now withdraw to discuss the quality of your thesis and your defense. I request that you and your company await the results of our deliberations and our return in this room.
The PhD defense has now ended. The degree committee will debate the candidate's performance behind closed doors. This process usually takes about 10 minutes.
Long road to the south side. 10 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and die. All your time, 'cause I'll go the extra mile. Long road to the south side, 10 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and die. On the dash, got my laces tied. Long road, I don't waste no time. Break rules because fate decides. With the team and we chase the light. I make a move, fall down, shake it off. I hate to lose, bad branch, break it off. No room for negativity, praise and love. Prepare for deep part cause we're taking off. Take the mileage, traveling so far from home. Gathering knowledge, other connections. I put the time in to get everything I ever hoped for. It's a challenge and we all in. It's a better future that we go for. Even though these nights seem long, I know that I am never on my own. Know you won the battle once you've grown. side. 10 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and that. Long road to the south side, 10 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and that. Years can't fly by now, don't waste all your time. 'Cause I'll go the extra mile.
Mirko Belliato, the degree committee here present has assessed the quality of your thesis and your defense. In view of its positive verdict and taking in account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor Lorusso is authorized to confer upon you this academic distinction in accordance with Dutch university custom. And I invite your supervisor to now take the floor.
Dear candidate, do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
Yes, I promise.
By the authority vested in us by law and in conformity with the decision of the committee here present, I hereby confer upon you, Mirko Belliato, the degree of doctor and grant you all rights attached by custom and law. And as evidence of this, I now present you with a degree certificate signed by the rector, the secretary, and the other members of the committee, and affixed with the official seal of the university. You can put it there. Dr. Belliato, dear Mirko, first of all, I would like to congratulate you for this scientific achievement. I know how busy you are and have been with ECMO patients in the past, and actually also in the very recent past. But nonetheless, your motivation to pursue this objective was clearly so strong from the very beginning. As you know, I like very much working with you, and you also know that I've been thinking that your contribution also at the scientific society level would have been precious and meaningful. I think I was not wrong in all my support to you. And your nice scientific results, together with your commitment, for instance, again, as I said, to a scientific society like EuroELSO and the related activities, are a clear proof of your dedication to the clinical and research settings. You are also leading a group of investigator researchers with a final nice collaboration. You are the chair of a task force about innovation, and among these people with, again, meaningful initiative and publication coming from such a nice collaboration, which sees you as a respectful partner beside the leader. I hope, but I'm sure, you will keep on working this way with a strong dedication and motivation in the clinical and also the preclinical fields. Actually, your patient is certainly a major drive about ECMO. But I also believe that you have been spending a lot of energies to create networks and, I would say, friendship among peers, which is not a simple thing to do nowadays. I'm sure that challenging objectives are ahead of yourself now as a director of an ICU unit and with all the projects and plans you have in mind. I enjoyed working with you, and I'm sure that this cooperation will give us a lot more, always with the help of other colleagues and friends that we have now in the ECMO community. I like very much your creative ideas and the proposal you often put on the table when we have scientific discussions, which are, again, a clear evidence upon your open mind and great care about science beside patient care. Your scientific and cultural history, as one of the attendees of the famous Borromeo College in Pavia, founded in 1561 by the Bishop of Milan, Carlo Borromeo, nephew of the Pope Pio IV. One of the oldest university colleges in Europe, and part of one of the oldest universities in Europe, which is Pavia, founded in 1368. Where you attended your university period and studies have certainly given you a sort of imprinting which was instrumental in terms of dedication, motivation, discipline, and a broad view on how you face and address your scientific and professional challenges, as well as the visions. You won grants for in vitro study of new models of extracorporeal circulatory system, and then also using bone marrow-derived mesenchymal stem cells to prevent lung fibrosis in RDS or transplant alloimmune reaction. You have patents in monitoring circuit echo, and so forth. These are all the proof of your broad and versatile activities, particularly regarding therapies to buy time and to give to patients the chance of organ recovery through this time, right? Well, but this is somehow just a translational action coming from another of your passion, the watches, that you are so fond of, a collector and a master in repairing them. So we must acknowledge them. So from recovery from disease with time, with ECMO, to reduce your own stress, maybe you are also using some time measuring machines. I'm sure you would like to have a big clock on top of the ECMO machine that you will take care of, and it will tell you the time that this patient needs to recover. But I'm also sure that with such a patient, which means being patient as well, but in a different way, luckily, than the patients, you are more prepared than anyone else to appreciate what ECMO does, giving time to your patients. So, at the end, two patients with a lot of crossovers and converging concepts, time to recover and time to adjust. So, let the time be with you, let the time be with you, and your precious watches, keeping always a timely eye on your ECMO patients. Finally, let me congratulate, obviously, with you, your companion, your children, your parents, for this well-deserved recognition by the University of Maastricht, since they were and are part of it, and I'm sure that you will keep on going this way with your aplomb and ingenuity within your collaboration and friendship, but always with an eye to the time, whether related to an ECMO support or to a precious watch of your collection, or most likely and hopefully to both of them. So, again, congratulations.
Thank you.
Dear Dr. Belliato, also on behalf of Maastricht University, I wish to congratulate you. I enjoyed your presentation and also the lively discussion, and I want to wish you a lot of success in the near future. And hereby I close this ceremony. Now I want to give the floor shortly to Professor Müller to give him the floor to congratulate the new doctor, the young doctor.
Dear candidate, I'm afraid you lost the status of candidacy. You have made your thesis, congratulations. Don't forget, in one way or the other, we remain candidates all our life. But concerning your thesis, you made it. You have done very well, and I'm really looking forward to our ongoing cooperation within Europe to improve ECMO for the sake of our patients. That is what you spent your life for. Thank you very much for it, and all the best for the future.
Thank you. Professor Grasselli.
Yes, thanks. I am very happy to congratulate Mirko, who is a great colleague and friend, for this very important achievement we have done and we are doing together, both in the clinical team. I acknowledge the
Thank you. Thank you so much.